Give it another minute.
Sure.
I think we'll just go ahead and start. Good afternoon, everyone. My name is Rob Murphy. I'm the Executive Director for the Institute for Global Health, and I'm also the John Fair Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern. Thank you for taking the time to join us this afternoon for our latest installment in the Institute for Global Health First Friday seminar series. Today's topic, as you can see, is collaborative research partnerships in Sub-Saharan Africa, exemplar from Cardiovascular Research Training Program. Please take a moment to follow us on Facebook and Twitter, hashtag FSM Global Health. In addition, we welcome you to become an Institute for Global Health member if you aren't already. You will receive access to specialized resources and services that support research infrastructure development. For more information, you can visit our website at globalhealth.northwestern.edu/members. Today, we are very happy to have Dr. Gbenga Ogedegbe join us for a timely discussion on his collaborative research partnerships throughout Sub-Saharan Africa, specifically his cardiovascular research training program. Dr. Ogedegbe is the inaugural director of the Institute for Excellence in Health Equity at NYU Langone Health. He is the Dr. Adolf and Margaret Berger Professor of Medicine and Population Health at NYU Grossman School of Medicine, where he serves as Director of the Division of Health and Behavior in the Department of Population Health. He's a leading NIH-funded scientist in health disparities research. He has led numerous NIH-funded studies for cardiovascular disease risk reduction with a focus on developing and evaluating clinic-community linkage models of care to address racial disparities in health outcomes. Dr. Ogedegbe is a member of the National Academy of Medicine and the United States Prevention Service Task Force. He's a fellow of many scientific organizations, including the American Heart Association, American College of Physicians, and the Academy of Behavioral Medicine. After obtaining his MD degree in Ukraine, Dr. Ogedegbe completed his residency in internal medicine at Montefiore Medical Center, followed by a fellowship training in health services research and clinical epidemiology at Cornell, during which he received his MPH from Columbia University Mailman School of Public Health. Prior to his current position, he was a faculty member at both Cornell and Columbia in New York. There will be time for questions following the presentation, in which we welcome you to submit your questions specifically through the Q&A feature at the bottom right-hand corner of your screen. And now, Dr. Ogedegbe, I turn it over to you, and thank you very much for joining us today.
Thank you, Dr. Murphy, for having me. And I'm truly honored to be for this academic year, the first speaker. So I thought I would share some of my expertise just to give folks a flavor of what I do. And the objectives of the talk today is really fourfold. Give you a sense of the state of the capacity strengthening for research in Africa. Outline what I think are the priority interventions for strengthening research capacity in Sub-Saharan Africa, and share the experiences we've had from the Cardiovascular Research Training Institute. We call it CART. And then give you a sense of what I think should be our future directions in this space. So here's a very popular, I think, publication called, A Decade of Development in Sub-Saharan Africa, Science, Technology, and
Gbenga, sorry, Mark, we cannot see your slides right now. Are you able to share them?
Oh, sorry.
No problem. I think you can see them, but we cannot.
Yeah, let me share them.
Thank you.
I thought I did. Okay, so share.
Perfect. Yeah.
Can you see them now?
Yeah, we see perfect. We got it.
Good. So I'll go right back.
Thank you.
Sorry. So the objective really is fourfold. Give you a sense of the state of research capacity strengthening in Africa. Outline priority interventions for strengthening capacity for research in Sub-Saharan Africa. Share the experiences from the Cardiovascular Research Training Institute. That's the training grant that Dr. Murphy alluded to. And then give you a sense of what I think are the future directions in this space. So here's a very important publication I feel everybody in the global health field that is doing work in Africa should take a look at. It's funded by Elsevier, really looking at the state of research capacity strengthening in Sub-Saharan Africa. So if you look at it, really, Africa has done a good job. Now this data is a bit dated, but 2012, between 2002 and 2012, they looked at all the research output across most countries. Africa has greatly increased both in quantity and quality of its research output. But overall, the number of articles and compound under Great Road, that's how the metric they use to look at how often and how frequent things are happening in terms of research output. For the Sub-Saharan African region and comparator studies, what you see on this slide. So on the y-axis here is the number of total articles, and on the x-axis is the year of publication. So right here, if you can see my cursor, this is Malaysia leading the pack. Then you have South Africa. When I talk about Sub-Saharan Africa, really, with respect to research output, sometimes I would talk about taking out the data from South Africa, because it's important to appreciate the apartheid and the colonial institution there for many decades, and the infrastructure built as a result of that compared to the rest of Africa. So I'm going to be alluding to that quite often. If you look at West and Central Africa, the CAGR growth is only about 12%. South Africa alone is 10.5%. And then look at East Africa, even less. And then you look at Vietnam and the rest of the continent, you begin to see a big difference here. So if we include South Africa, then the total Sub-Saharan Africa is about 10.5 plus 12.2. But if you take that out, here is South Africa alone. So again, the point I'm making here is that the rest of the world is moving ahead, but Sub-Saharan Africa is lagging. So about Sub-Saharan Africa's share of the global research increased from 0.44 to 0.72. So it's increased, but think about it. It's all still less than 1% of the world output. For a continent that's about 1 billion people almost. That's about a fifth of the world population. West and Central Africa alone increased from 0.23% to 0.4. Southern Africa minus South Africa, even worse, 0.07 to 0.09. And Sub-Saharan Africa still accounts for less than 1% of the world's research output, as I mentioned, despite representing 12% of the global population. So, but 45% of all of this research I'm talking about is actually in the health sciences, as this slide adequately shows. So it's important that when we talk about the health sciences, this is where most of the action is happening as it relates to research. Most research in Sub-Saharan Africa relies heavily on international collaboration. I'm visiting faculty like myself, Dr. Murphy, Dr. Hoffman, and other folks that are doing work in the global north for their research output. And as you see on this slide here, on the y-axis is the international collaborations as percentage of the total output. And on the x-axis is the countries as they are depicted. And when you take a look at this very carefully, what you begin to see is that most of the collaborations across the board is actually coming from the international output. When you look, though, at the interregional collaboration between Sub-Saharan African regions, it is rather poor or non-existent, anywhere between 0.9% to about 3%. So in other words, 79% of the collaboration between the North and the South is where the action is. But within the system itself, in West Africa or Sub-Saharan Africa, is only 0.9% to about 2.9%. So people do a ton of work with other folks, but not with each other. And some of the reasons for this, people have alluded to poor funding for research by African countries. Africa has to take its own blame on this as well. If you look at the funding for research by African countries, it's only about 0.3% of their GDP. That is about 7 times less than what developed countries or the global north countries actually allocate to research and development. On average, though, Africa has only 164 researchers per million compared to about 1,000 per million in the global north. In Sub-Saharan Africa alone, there are only 80 researchers per million in the population. So it's really dire when you begin to think about the breadth and the depth of work that is what that is happening and the deficit thereof in those. So what are the priority interventions for strengthening capacity in the region? There are several ways to think about it. Again, in order not to reinvent the wheel, I want to really draw your attention to this, again, important review that's called Changing Mindsets, Research Capacity Strengthening in Low and Middle Income Countries, not just Africa, but really as a whole. This was put together by the Global Forum for Health Research. I love this a lot. I've read it several times, and I really urge you all to take time to just take a look at this. And so most of the issues I'll talk about actually stem from that. And this is the backbone of how we actually proposed our own training grant in Nigeria and Ghana. So several things. In addition to supporting individual research investigators, focusing far more on supporting institutional capacity will be crucial. And this requires a change in the mindset of funders and other international organizations as well. We can't keep talking about metrics that has to do with papers and grants. Those are process measures in my mind. We've got to focus a lot on the lead or the lag measures that has to do with building and strengthening the capacity institutionally. Concrete action to promote retention of skilled and experienced researchers in the region is required. Well, this will require improving conditions of service. I think things have since changed between 2012 and now. If we take out the COVID pandemic, things have since changed in that direction. Job security, career pathways. We don't even have a way to define career pathways. When you look at those of us who are physician scientists, where you have a huge clinical load, you have a huge teaching load, and yet you've got to do research. And then finally, I believe that even in the setting of all of these barriers, the opportunities for engagement with peers is crucial. The whole idea of the North-South collaboration is important, is necessary, but I really don't believe it is sufficient, because what that does is it deepens the reliance on the Northern funding and really deepens the whole aspects of the global colonization of global health. I think there has to be opportunities for how peers can engage with each other. Some funding agencies are beginning to think along these lines, but I think you have those requests for proposals come out. They put a lot of this language in there, but then when things are funded, it's very quick for folks to actually revert to the old ways. I think changing mindsets is going to be crucial. And as we train the next generation of scientists, we've got to actually make this drum beat much louder than it has been in the previous decades. Other things that we can do, increase collaboration between and within low-income countries rather than competing for resources. This requires a change in mindset within the Southern institutions. Because what you often see is that the metrics in how you talk about the advancement of scientists, I'll say, for example, in West Africa, has to do with, can you win a grant from foreign funding agencies? I think winning a grant should not be what the issue should be. It should be when you win a grant, does that change the fabric and the fiber of how research is conducted in the region? Recognizing and exercising their power to actually address the perceived power imbalance in North-South collaboration. A fabulous paper came out, I believe, in Nature or in Science earlier this year that talked about the whole idea of the global funding. I think there were actually a collective of African scientists that looked at most of the funding that comes in, close to $1 billion. When you look at how much of that money actually is expended in strengthening capacity in the region, less than 20%. I think that's disheartening with all of the funds that has been spent, but not much is being spent. I think it's the power imbalance that often begins to trigger that kind of mindset. And also, there's got to be a way to insist on some form of equal partnership with explicit capacity strengthening components, because most funders require the involvement of local partners. So at the end of the day, inherent in collaboration between the global North and the global South is the idea that without the partners on ground, all of these things just won't happen. So there's got to be a change in the mindset. And I think this is what Chinua Achebe will refer to as entering your house through your own gate, not through the gate of another person. I think it's important to appreciate their ability to claim that space and begin to really think in collective collaboration along those lines. And then, you know, when you think about all of this, I think that is where we're beginning to move towards. But I worry, and I'm still concerned that we're not doing enough in how we really look at our training programs to want to address some of these issues I've raised. So we use an exemplar of the Cardiovascular Research Training Institute. That's the grant that we have graciously funded by the Fogarty Institute for Institute Center in the US at NIH, really to help us look at building capacity around cardiovascular research. So I'll share some of the structure of that program, some of our accomplishments, and some things we've done since then, and how some of the barriers that we also that we face with you. So this program actually is a collaboration between Loyola University. At the time, it was Richard Cooper, world-renowned cardiovascular epidemiologist, done a ton of work looking at both the genetic and the social origins of hypertension in Africa, in Black populations, broadly speaking. And his colleague as well, Professor Bamidele Tayo. Professor Tayo has taken over the PIship from Richard since the renewal of the grant. And we have University of Ghana, Professor Richard Adanu, who is the current rector of the Ghana College of Physicians and Surgeons, and used to be at the time the dean, actually the vice dean when we got the grant in 2012 of the University of Ghana School of Public Health, and myself, I'm at NYU. The renewal of CART just recently, a year ago, is now called SCART, S being stroke, and now has all 3 universities, including UCSF with Professor Bruce Obiageli, as well as Utah School of Medicine with Professor Kola Okuyemi. So now we've broadened it out to actually have 5 universities with, and also University of Ilorin in Nigeria. So 2 African universities and 5 US universities. Okay, what is CART all about? Well, it's a collaborative training grant, as I just said. The goal was to develop junior faculty, postgraduate scientists, and those who matriculated from the MPH, PhD program students as independent investigators. So we had a whole cadre of scientists that wanted to develop across the entire continuum. Training was going to occur entirely in Ghana. We didn't have any intention of bringing anybody here. Remember, the whole idea is to strengthen capacity within the institutions. And we made that case, that until we do that, what we're really doing is bringing people here, we're training them here, then we'll have them go back to their countries. Look, I didn't go back yet, although I spent maybe 5 months of my time in Africa running research and training grants in the past 3 years. But still, I came here 30 years ago and I'm here. So training people in the context of a different setting and then expecting them to deliver research in their own context that is totally different, I think is a misnomer. I'm not saying that is not important. I'm just saying that if one will build capacity, that is one way to not do a good job for a very long time. I think that's where we are today. The trainees are mandated to form a multidisciplinary research group. Very important. Earlier on in the game, we realized that collaborative research is key. Most of us are in fellowships where you talk to your colleagues, and it is those, what I call serendipitous conversations you have with your colleagues that actually spurs a very important research question. And then finally, we adopted a long-term training model that requires mentees to attend the program for a period of 2 years. So it's not just a 1 year we're done, it's actually 2 years, because it takes a long time for you to actually formulate a research question, ask that question in a way that's actually going to integrate what you're doing to the healthcare system, get it off the ground, publish the data, and then begin to think about funding for its sustainability. So during the first year, trainees have to attend 3 intensive courses, 2 weeks each, around the fundamentals of research methodology, comparative effectiveness research, health services research, advanced biostatistics. We strongly believe that, and if you're going to do research, you don't have to be a statistician, but you've got to understand the language so that when you're talking to your colleagues, they can better appreciate what you're really talking about and what you're asking them. And of course, dissemination and implementation research before it became a lingo that we all use today. And in the second year, our mentees participate in various career development and mentorship activities. And then they have to then hone in the acquired research skills in the previous year to develop and implement individual research projects, and then prepare their manuscripts and whatever grant opportunities happen to be available in their setting. So this is how we proposed it, and that requires us to have, we start sometime in January, 2 weeks. We have 1 week. We used to be 2 weeks, became 1 week intensive in May, and then we have 2 weeks in September. And for each of those times, we'll bring maybe about 20 to 25 or sometimes 30 established investigators and scientists from here and from Europe to Ghana. And then we have the program. And then they would drive that. And then we'll pair people up with those investigators to become their mentors. But of course, the program directors, the 5 of us, actually have monthly seminars with the trainees to talk about where they are with their studies. Initially, we started doing this by looking at individual research projects, and we quickly abandoned that idea because we realized that when we do that, it's often very difficult given the workload that some of these people have already. Other than the PhD and the MPH students, who truly that's all they do, for the physicians in the audience and the faculty PhD in the audience, it becomes very difficult for them to actually take on an individual research project and then have a huge teaching load or a huge clinical load. We began to then say, we've got to figure out a way to actually make sure that we join people together to work in groups. And they have to ask a research question. It helps them to collaborate. And then with each group, you've got to have a good sense of exactly how your work is going to have impact and significance to the healthcare system. So in the first year, the idea is to have train a cadre of 10, 10, 10, 10, with about 4 cohorts, a 5-year grant. What we realized was that we could do the same thing in Nigeria. So with the prompt of Professor Tayo and Richard Cooper, we actually began to collaborate with University of Ibadan and to bring trainees from Nigeria as well. And that allowed us with our second cohort to begin to have a really cross-country interdisciplinary collaboration between folks from different countries. And we're so gratified by that because it became clear to us that that's the way to go. So in the renewal, which we have now, we have a holistic program that's actually having those 2 countries and the 5 institutions here. So what does the structure look like? This is what it looks like. You enroll, we create a mentoring program. We have the sessions I just talked about. We have the monthly webinars by group. And then we have a writing group that they have to form. Again, you have 4 or 5 people working on a similar project that is being implemented in both countries. Matter of fact, they have to get separate IRBs, but they're all working together. And then we bring everyone together with each of the sessions that we do. And the output that we're looking for, of course, is academic promotion, scientific articles, professional presentations, and grant applications. We quickly abandoned the whole idea of grant applications because we realized that the infrastructure to write grants is just not there. And the metric that they use at the universities has to do more with the papers that you publish. So we then focus a lot of our efforts in our 3rd cohort on talking about papers. And also I have to give a huge shout out here to Professor Michael DeBond from Vanderbilt School of Medicine. Because what Mike had done, I'd invited him to come with us, to come teach, and he was able to form a group that was going to focus squarely on sickle cell disease and the health services research thereof. So he formed the group from part of the trainees in both Nigeria and Ghana. And today, that has evolved to, I believe, 2 R21s, 2 R01 grants, and huge collaborative work happening in prevention of secondary stroke in children with sickle cell disease. Again, it was there we quickly learned that what we have to focus on is 2 things: the papers and a specific research question that actually addresses some of the challenges that's being faced in the country. So some of our accomplishments, again, caveat, this is between 2012 to 2017. Grant was renewed 2 years later, even though we continued with other training grants as well. And we continued that model. We did not stop. NYU was generous in supporting us with funding to make this happen. Just to be clear, the $1.2 million that we got for the grant across the 5 years was nearly not enough. I think we spent close to twice that amount, because we have significant funding from some of our discretionary funds to actually make this happen. So if you look at what they achieved, postcard about, this is looking at a cohort of, we're meant to train 40 people. We trained probably about 74 people total between 2012 and 2017. You're looking at, about 25 peer-reviewed manuscripts, about 6 book chapters. Scientific abstracts were a lot. Some did get their K awards, even though I frankly don't believe in that, because infrastructure doesn't support it well enough. If there's that support, there may be things that have changed now. We push a lot for the scientific abstract and the publications. If we combine all of those people together, then we're looking at probably about upwards of about 100 and something publications that came out of this. So as part of that, we then said in our 4th year that, at the time I was the vice dean for the NYU School of Public Health that had just been formed in 2012. And we began to create, NYU has a campus in Ghana, began to create a collaborative research with the School of Public Health. So Richard Adano and I had people that we mentored together, and we had actually forged a collaboration whereby we had University of Ghana School of Public Health faculty being appointed to our own School of Public Health here. And so we wrote a grant to look at research integrity training program. It was going to be between NYU School of Medicine, NYU School of Public Health, and University of Ghana School of Public Health. And so this was myself, Professor Amos La, Dr. Art Kaplan, who is the Division Chief of Division of Ethics in our Department of Population Health here. And we had 2 questions. One was, we wanted to produce a core group of research ethics and integrity experts who will become the mentors, the teachers, and the policy shapers in Ghana and the region around biomedical ethics. And we also wanted to establish a master's program in bioethics at University of Ghana School of Public Health. So what we did then was we provided training. We're now in the 4th year to about 30 fellows to date within that program, using the infrastructure that we established with CART. If you remember, we had CART. So it was 3 cohorts of 10 years, 2 to 4. And they are the intensive courses, the same format, nothing changed. They actually worked with some of the CART trainees. And the idea was to then really have practical experience at the Ghanaian IRB and REX, and then have mentored collaborative research projects with publishable manuscripts and ethics, and as well as career mentorship in that space. And we also provided opportunities for the trainees to earn a master's in arts in bioethics at the NYU Center for Bioethics for 6 fellows who will become then the future faculty for that program. So one thing I forgot to say is that when we renewed our grant, the D43 CART training grant, some of the trainees that we had trained actually became faculty. So they are now the faculties that are mentoring the other groups along those projects that they work across. So we're doing a similar thing here. And I'm really very happy to announce that curriculum development approval was launched in 2021, just recently, for an MSc program on bioethics at the University of Ghana. So we're building capacity, not just individually, but we're using that capacity to actually advance capacity at the institutions as well. We had proposed this program at some point with Prof. Obiageli to actually do stuff, we call it GRASP, Growing Research and Advanced Research in Africa. It didn't get funded. NIH wasn't too thrilled about it for some reason. Got a good score, but we ran out of gas. We just didn't pursue it any longer. But I strongly believe in this model. I think now that we've demonstrated that we can make this work, probably maybe what is for us to go back and begin to establish this model as well. And beyond this, we had another R25 also funded by Fogarty. I was looking at what we call information, communication, and technology. That was how we were able to establish REDCap in the region. And so all of these ways of building capacity, to me, is the way to go. Why is it the way to go? Because the future directions in research capacity strengthening has to do with how we decolonize global health. And this will be the last part of my presentation. And I thought it's important before we talk about decolonization to show the history. And this is a wonderful slide put together by one of the folks on my team here, Ashley and Rakira. And what you see here is that colonial medicine is how everything started. It became tropical medicine. Just in the name alone, Desmond Tutu said his language is powerful and important. And then you have international health. I'm really thinking is the health that happens elsewhere. To me, health is universal. I think then it became global health. Sometimes you wonder, what does this really mean? So the field has historically been driven by the agenda of institutions in high-income countries, with power dynamics in my mind that have disadvantaged the partner institutions in low middle-income countries. And 85%, I want to stress that 85% of all the global health organizations are headquartered in North America and Europe. Of course, Amadou said that, the hand that gives actually dictates and it stands on top. That's true, but we've got to be creative in how we think about these partnerships now, because the inequities we saw throughout the COVID-19 pandemic really laid bare for us the need to address the power and privilege imbalances in global health as well, not just with us in the US here, but as well as global health. And so in my mind, we've got to think, when we think about training programs, we've got to think in tandem with how we can decolonize global health as well. There's got to be a way to decolonize our minds. I grew up in Nigeria, which, as you know, got independence in 1960, about the time I was born. And so we call ourselves the independence children. And when you think about how those of us who grew up in that era think these days, there's often that idea that we've got to decolonize the mindsets. And I think Fela Anikulapo Kuti of blessed memory actually talked about this in most of his songs when he talks about colonial mentality. What colonial histories have shaped our thinking and continue to influence our way of engaging in research. We've got to really, what was the word I'm looking for? We've got to unpack that in a way that allows us to think through the lens of this in thinking about strengthening capacity for research. And until we do that, it really will be difficult for us to arrive at a place where we can begin to appreciate how we need to move forward. So what can we do to make that happen? I think what it would take is that we've got to think about decolonizing global health in medical training, very important. We've got to think about mitigating the international donors and funders that fund projects that address their own interests, not the interests of the community where people are. I think that's also very important to appreciate. And we've got to reimagine what global health could look like. We've reimagined it in the old days from, colonial medicine to travel medicine to international health. Now it's global health. We can reimagine that differently as well. Health is health. Health is everything. It doesn't have to be really impacted by regions that we live in. Of course, context matters. We've got to reimagine how we define global health as well. And some folks are beginning to work in this space. Maduka Pai is talking a lot about power, privilege, and coloniality in global health. And other folks have begun to think about this as well, both here and abroad. And I think we've got to drum that beat to the extent that we can. And another point I would say is that it's important for us to think about, who sits on these editorial boards. You put in a paper to Lancet talking about, an important aspect of work. I'll be very specific, task shifting strategy for hypertension control in Sub-Saharan Africa. It's not of interest. What do they want to see? The molecular base of hypertension. We're never going to find that, because what drives hypertension really is not so much the biology, but the zip code and the context and the lived environment, the social determinants that really drive the equity we're seeing across the world today in hypertension. Nothing against Lancet, but I think we've got to begin to reimagine what these things mean and have people on those boards who can better truly understand the context of the environment to begin to decide how we get these things out there. I think it's important. I have the power to talk about this because I'm established, but there are those who don't have that power and often are afraid to speak up to talk about these issues. I think if we're going to make progress in global health, it's going to be crucially important to address the global health inequities by really intensifying the calls for how we can decolonize global health and strengthening of our capacity in the local regions will really depend on how we craft these training grants that we have. And there's a tremendous momentum now to think about this. And I want to really highlight what one of my colleagues, Professor Collins Harry-Mbua, used to be the Dean at St. Louis College of Public Health and Social Justice, said in a piece that we wrote about. He was a huge fan and a key member of the CAT program. Here's what he said about future directions in research capacity strengthening. As researchers, we must commit ourselves to research capacity strengthening activities that not only strengthen, but also inspire health scholars to make a difference in their local context. There is urgency in promoting transformative leadership as we build and strengthen research capacity that is sustainable and balances two fundamental values: excellence in research and relevance, as well as leadership in setting local research agendas. This actually is the basis of our CAT programs. The grants that we have, the papers that the trainees publish, the work that the faculty does really has to do with hypertension, which today is about 30% of folks in Sub-Saharan Africa, diabetes, sickle cell disease, and a lot of the diseases that has to do with the social determinants of health that actually plague most of the healthcare systems in both Nigeria and Ghana. And we continue then to have our grants become the laboratory for how we do that work. I know that Dr. Hoffman is doing some fabulous work with Dr. DK Oji, whom we're also collaborating with. And other folks are doing similar work as well. But in our mind, if we don't look at those two fundamental values, then we've missed the boat. And in order for us to look at those two fundamental values, we're going to fail. That's okay. But failure is an opportunity really for us to envision our next phase. That's what the former president of Liberia said, President Ellen Johnson Sirleaf. And she says the size of your dreams must always exceed the capacity that you have currently to achieve them. If your dreams do not scare you, they're not big enough. It's big dreams to build institutional capacity in institutions in Sub-Saharan Africa to drive research. It is a big dream. It's not going to be done in 5 years, but that's the kind of dream that I think all of us have to dream as global scholars. So I'm going to end here and give you a beautiful view of New York City. We just went through the aftermath of Hurricane Ida. It's not as beautiful as this today, but you can have a dream to see what this is going to look like in the next couple of months. Thank you very much, Mark. Thank you very much as well, Rob. And I look forward to taking some questions.
Oh, thank you very much. Thank you. Very incredible. Okay, we have some minutes here to take any questions from anybody. There's the Q&A feature here. You should be using that if at all possible.
Rob, maybe as people are thinking, Gbenga, first of all, amazing presentation. I really enjoyed it. It's very inspiring. Can you talk a little bit about, I love the sharing that happens kind of across different time and space and levels of people. Just this concept of open science as a catalyst to be able to allow these networks of individuals to really grow and flourish in their local environments, but connecting with others across, again, time and space.
Yeah, that's a good question. Basically, what we're asking is that what did we do and how did we do it? Where we're having the investigators, let's say, or the trainees from Ghana work with each other, and then the ones in Nigeria working with the ones in Ghana as well. I think the key ingredient for that is there's got to be somebody driving it. So what we did was, in that very first intensive research program, the 2 weeks of that first week, we have at any given time for any cohort about 24, 25 trainees. So we'll say they have to break up. So if it's 25, you're going to break up in fives, and that'll be 5 groups. And then I'll say, honestly, Rob, I'd like you to lead this group because the work they're doing is in your space. Say, Mark, you lead the second group, Gbenga. So we divvy it up. And then in that very first week, we ask them to come together and come up with a research question. We tell them to be idealistic. Pretend you have all the money in the world. Don't even worry about the money. 5 of you sit down and they will spend about 3 hours a day, right? For that first week to meet together. Of course, with each of the mentors sitting with them to help them think through. The whole idea of that exercise was for them to appreciate that there will often be different points of view in what the title is, in what the idea will look like, in what the methods should look like. And then they duke it out. And then for the second week, they've got to present to their cohort, right? And so that 2 weeks, they actually begin to learn how to work with each other. We unveiled a lot of things in those 2 weeks. We began to learn ourselves that, the way we conceptualize research over here is totally different at the individual level from the way they do it there. And a lot of things come up that often make us feel like, well, are we really doing this the right way? So they come up with the idea, but it's an idealistic idea. Sometimes it has wings and it grows. Most times it did not. Then they come back in May. And in May, we sequestered them with 2 biostatisticians, Professor Tai and Professor Sapon. At the time, Dan used to be the senior statistician for the Jackson study. And they would sit down in a resort. Because if you do it in the city, the doctors, they are taking their phone calls, they're going to their practice, some people are, so we just put them somewhere where they have no access to anybody but themselves. And then they tend to work with data sets. And then they come back again with those ideas they had in January to flesh it out more. And then come September, based on the ideas that come up, right, in May, we'll then figure out who we want to invite in September to come to Ghana with us. So if the ideas they have has to do with a major area, we'll find somebody in the global health space to come give a talk. So I say, Mark, talk about the work you're doing in Nigeria. Talk about your career. And they're going to hear that, right? And then we say to them, you hear what Mark just said? Look at the methods he talked about. We'd now like you to come up with a realistic project, not one that, not one that is idealistic, realistic. I will give you $5,000 to $10,000 for you guys to work on that project. And here are the things we're looking for. And the moment they're done with that, they must come away in that last 2 weeks with a viable research project, which they then present again, like in the first 2 weeks in January, to their cohort. And then we have monthly sessions with them to help them shape it. Then they do the IRB, they do all of that themselves. Some began to say they want to do secondary data analysis. So at that point, if the research question they're asking lends itself to secondary data analysis, we try to discourage it, but if we think that the idea is really critically, locally, contextually impactful, we'll encourage it, and then we'll give them the data set, or we'll purchase it if needed. But then we get the curator to work with them through that. So that's how we build that. And honestly, when we're done, they continue those collaborations. Some of them are leading some of the African centers for chronic disease. They're doing stuff that, is their own voice, is their own project, is their own thing. Of course, we try to be true to NIH. So say, okay, we're going to work on hypertension, cardiovascular disease. We threw that away by the end of our second year because we realized that, that's how we get the grant. But, people want to do what they want to do.
We have a couple questions in the chat box here. One question, comment. Thank you for a wonderful, inspiring presentation. How do you balance the sometimes competing priorities and incentives for young faculty at NYU with the work to build capacity at the partner institution?
I don't balance it. I'm not going to give you an academic answer and say, yes, I do. It's very tough, and it's just difficult. So what I do is this. I'm interested in just 2 things. One is mentorship. At this stage in my career, I really value mentorship a lot. So the competing priorities I have in that space is I wear a lot of hats, right? So I'm a division chief and I run a large research center. So the Center for Healthful Behavior Change is one of the biggest in the department. There are about 12 of us and, everybody's research intensive. And I've got to mentor those folks as well. So what I begin to do then is say, okay, if somebody's working in an area that I'm interested in, that I don't have the juice to work on anymore because of this admin role, I will invest in mentoring that person and trying to build the young faculty. The other thing I do a lot of is I get myself involved in larger programs where I can lend my expertise, but it's to a larger group. That's why our AHA grant that we just got is huge. It's 8 institutions. We have to train people. But when you're working with other senior investigators and mid-career investigators, it's easier to have impact because then it's not just you alone carrying that on your back. So it's difficult. So what I would advise, so for the partner institutions, it's been very difficult. In the early years in 2012, when we wrote the Fogarty training grant, remember I just became vice dean for our new college. At the time it was an institute for global health. So I had to travel to Ghana anyways. In fact, I'll tell you the story. Showed up in Ghana, School of Public Health. Fred Binka was the dean at the time. And I was watching the dynamics and the optics of what we're doing. We went to all the hospitals. And it just became clear to me right there that, wow, I told the VP, I said, look, Bob, we have a problem. He goes, what's the problem? I said, the problem is training. We can bring out the money we want in the world. We can do what we want. Honestly, we've got to train these people. So he kept quiet. He didn't say much. I didn't know he knew that was the problem, of course. That's why he invited me with Luke Goldfrank, who was our emergency medicine professor and department chair. And when we got back to the States and we're just thinking about what we're going to do, he said, oh, Gbenga, I will give you $25,000. Why don't you see if you can do some, he goes, what do you need to train people? I said, well, give me 25 to 50K. I'll bring about 5 people to Ghana and we'll talk about hypertension and then we'll train people. Give me 25K. The rest is history. RFA came out. I looked at all the big wigs who applied for this grant. I said, everybody does a fabulous job. They've done a good job, but what I did not see was how do you begin to mentor people in the local context and have it happen there. So we proposed that and we got funded. Now, I was also at the time, 2012, I just got into NYU 4 years at the time. I was leading a very thriving center for, Healthful Behavior Change. We just got a large stroke center grant as well. So it wasn't easy to do it. So I'm not saying it's easy, but it was, that passion made it easier for me to probably make it happen. And then the rest, people just do well and you have no choice. You just want to support them. But these days, it's gotten more difficult. So Professor Tayo leads the program instead of me. Other folks are leading it, but I still take part as part of the collective. Sorry, Rob, for a long answer, but I think stories matter.
I know where you're from. Okay, we got another question here, Dr. Ogedegbe. Excellent presentation. How are you ensuring equity in the selection of trainees so that people from varied ethnic and socioeconomic backgrounds are represented?
Okay, so I don't do that. Let me just say straight up. So when it comes to science, at this stage in the science at least, we want to build a cadre of people who are solid. And then we want to use them as a scaffold for building the next generation of people. If we do national representation, and if it so happens that the group that we have is representative of the ethnic groups that we have in the country, I'll take Nigeria or Ghana, for example, then great. This is more of an issue in Nigeria. I'm Nigerian, I know that we have 6 geopolitical zones. And people say, they've got to be represented. That's how the country was founded. That's what we've done over the years. That's how I got scholarship to go to study in the Ukraine. But you still have to qualify. You still have to meet the entry criteria of somebody who applies. So we have an open application process. When we did the open application process, we had to make sure that the department chair or the supervisor of the trainee actually grants them permission. We're talking about 6 weeks a year, and they're talking about 1 hour every month. That's a lot of time. What we quickly found was that the department chairs were selecting their favorites to the program. And they come, we look and say, but you can tell people who want to do stuff, or you can tell people who I call the African scientist syndrome, where they attend every training program there is out there. When you ask them to show what they've learned, they show you, but then when you look for the demonstrated evidence of what they've done with it, it becomes difficult. There's just no capacity. So we began to then become more selective. We took people who we know are going to succeed. We cherry-picked because the early wins matter. Once we get the early wins, then it makes it easier for us to build on that. I think we're at a stage now with the 74, so we've trained. Now we have another 25, and we have another 25 coming up again. I think we're now in a good place to begin to think about representation across ethnic. Now, socioeconomic background is a different story. So the issue of science in Africa is that, look, honestly, if you ask me, what are my chances of becoming a professor of medicine today if I grew up in the US? 0, maybe 1%. Because my parents were not, they're not educated. My dad had elementary school education. My mom was not educated. So it'll be 0, right? But in Africa, the good news, maybe not today, at least when I was growing up, public schools cater to people regardless of the socioeconomic status. So all of us find ourselves in classrooms where we have colleagues whose parents, are ministers of health, and we have colleagues whose parents have no education. So the SES was not that much of a problem. I don't know if that has changed. The school system obviously has gotten worse in terms of the public health school system, public school system. But so we don't look at the SES, we look more at the ability of the person to make it happen, because we're still early. This is just our first renewal, right? We're going to see how well we do in the next 3 years. So we're intentional in building that way.
All right, we got another question from Anubar Agarwal from Northwestern. Thank you so much. How do you support capacity building of a cadre of physician scientists in LMIC settings where, as you mentioned, clinical responsibilities can be overwhelming and there are few mechanisms for protected research time?
I love this question. So let me tell you about protected research time first. Here's what we say. So they say, well, Prof, they'll call you Prof over there. Prof, we don't have the money and the funding that you have. So I said, that's true. I said, but nobody gives us money to do research. We don't have protected time. So I asked them 2 questions. I said, tell me, is your salary paid? They said, yeah, we're fully paid. I said, okay. If you don't bring in grants, do you get your full salary? They said, yes, we do. I said, well, I don't. I have to bring in 60% of my salary in research funding. If I don't do that, well, the school may give me a 2-year break. But by that 2nd year, if that's our policy, they began to draw it down, even though I have tenure, right? So the question then becomes, you don't think you have protected time, but you actually do. So the word protected time is not a concept that I agree with when it comes to African regions, because you're fully paid. Your salary is guaranteed. Nothing happens to your salary, whether or not you get a grant. So the way we try to balance that's the second question. The first question is, how do you make that happen with all these responsibilities? We find people who have the passion. It goes to the other question. We can't do this in a representative manner. I tell people it's going to be a hard slog. The good news is that you're a physician in a resource-constrained environment, or you're a scientist in a resource-constrained environment. So you've done the hard work already. Anything you do from now on is icing on the cake. The problem is you don't see it that way because you're used to just getting those funds. But now we're asking you that if you do a good job in the next 3 years, you tell them it's 3 to 5 years. Training program is only 2 years, but you've got to put that extra year in at that same pace. You will be able to get those grants and then do even better. And so that's the way I argue that. It's a huge clinical load, that is true. But by the same token, those clinical load actually is how they get their salary paid. It's a huge teaching load, that is true. But if you're good at it for the past 10 years, you can train your TAs to assume those roles for you, frees up your time to then focus on what you're passionate about. So I tell them, if you don't have the passion, it's okay. Don't feel bad about that. You can still contribute, but it just won't be the person driving the research.
We have maybe time for one more question. I'm going to ask it myself. So the Fogarty International Center has really made some pretty dramatic changes in the last 10 years. And what do you think of those changes? And what else do you think needs to be done? Because they are funding the bulk of this training programs, research training programs in Africa.
So I think, so let me ask first, Rob, which changes are you alluding to? Because there are a lot of changes. I'm on the board for Fogati, so there are a lot of changes that's happening.
Well, for instance, I was sitting on one of the training study. I'm on several study sections, okay? Some ad hoc, and there was I was on the K43 awards and whatever, and the D43s. So the summary statements are coming back such that if you don't have an African or LMIC co-PI or MPI, you're getting severely criticized and marked down. That is a change.
Yeah.
And I mean, I thought that was going in the right direction. And they're encouraging, after the end of several of these training cycles, that the grant actually changes over completely to the LMIC institution. So I've seen that, and I thought that was really a positive thing. And I was just wondering if you feel the same as I do, or if you think something else has to be done.
Yeah, I think both. I think it's a solid change. I gave this talk actually, in full disclosure, to the Fogati board in 2017. And at the time I came off of the D43 training programs study section. And I came off very disappointed. And I shared my thoughts with Roger. And so when I looked at some funding institutions, they've been funded for the past 20 years. When I look at the number of PhDs they've trained, I'm not going to mention the countries. It was just eye-popping. And I said, we just got our own funding. We just finished our first cycle. Look at what we've done. And I was just like, wow. So that is a positive change. That is a huge positive change. I love it. I think the other change they have to do now, in my opinion, so they have the data science, you're having all this H3 Africa. That is all great, but realize also that, if the infrastructure is not there for those countries to absorb it, is a problem. We're talking about training. Let's just focus on training for a second. So that's a positive change. What I haven't seen, I know we have a hard stop. What I haven't seen though, is that when you do that change, do you actually assure that you don't have that many training programs in one country? So some institutions have 5 D43s.
Oh yeah.
If I was the president or the dean, I'm going to have to bring them to a round table. Make up your mind, folks. Let's make this much stronger. We're investing a ton of your time in these settings. But so that's the other change I think we have to think about in prioritizing those funding. But I agree with you totally. That's a step in the right direction.
Okay, we're at the top of the hour. I want to thank Gbenga for taking the time to share his insight and expertise with us today. And I want to thank the audience for being here and for making these questions and stuff. I want to also invite everybody to our next First Friday seminar, which is on Friday, October 1st. More details will be coming out. And again, thank you everyone for joining us today. And for those that have registered, a recording of this webinar will be shared by email shortly. And that concludes today's webinar. Thank you again, Gbenga.
Thank you.
Thanks,
Mark. Thank you.
Thank you all.